that Dr. Potee will be speaking on. We know your time is valuable. If you have any afterwards, there is kind of a sign-in sheet out there. If you hadn't signed into Evite and you want to get information that you may ask for during the presentation, write your name on that sheet out there, and then I'll make sure it gets out to everybody. But I want to thank you all for being here. I want to thank UMass Dartmouth for hosting us. This came from a grant from NACHO, National Association and City and County Health Boards. And we're really grateful that Dr. Potee can come speak about this very important subject. And next I'm going to pass it over to a local in the Dartmouth Police Department. He is going to talk about what they're doing locally with the opiate prevention programs.
Can everybody hear me okay? Yep. All right, I'm just going to bend this up a little bit of a height difference there. My name is Kyle Coster. I'm a detective with the Dartmouth Police Department. I've been on about 28 years. I can honestly say that the last 3 years have probably been the most traumatic for our department as far as what we're experiencing with the opioid crisis that's currently going on. I like to say that we're winning the battle. I'd probably be lying by saying that. How many families here have been affected by opioids? So quite a few. As a police officer, I just want to say I'm sorry to all of you. Because to the point of, just to break it down into simplest of terms, we suck. We really did. Going into this whole thing, we weren't prepared for what we were going to see. And, in our philosophy or our take on a lot of things is, okay, it's just another junkie. It's just another shoplifter. It's, just another dirtbag, scumbag. Every word in the book that you can think of. That was the mentality that probably the majority of us had. The pivot point for me was probably I've been a detective about 5 years, 6 years, and the pivot point for me was when I got assigned to inspect all the bodies. I was the guy that got called out for anybody who died. And I had one afternoon, it was a Sunday, I remember like it was yesterday, it was a Sunday, it was probably about 80 degrees. In one of our local motels, I got called for a body. Nobody gave me any particulars on it, and when I walked into the room, I probably saw the worst thing I'd ever seen in my life. It was a young lady who was 8 months pregnant, hanging from a shower curtain. Now, you can imagine just the horror of seeing that in and of itself. When I started to hear the backdrop of this young lady's history, it really changed me. It hit me hard. I can honestly say that I wanted to make a difference at that point, or be part of the solution. I think we're probably all living in a fantasy land if we think we're going to eliminate this problem. The nice part is that I think we're at a pivot point now where a lot of agencies, individuals are seeing it for what it is, and it's something that we have to work on together. The one thing that I'm a part of that I'm most proud of right now is it's a town-wide organization called COPE. It's an acronym for Community Offering Prevention Through Education. The one thing that I've seen is that everybody wants an acronym. I'm sure everybody has seen that we have PPOA, MPOA, MOPSI. We have all these different acronyms. Sometimes I have to put them in my phone just so I remember what they stand for. That being said, I can honestly say that I'd like to see one acronym that kind of facilitates all of it, and it's US. I would love to see everybody on the same page with how we're moving forward. Just some statistics that I don't want to bore you with too many. In 2016, we responded to, and these are documented, 44 overdoses in Dartmouth. So far this year, we've hit 59. So we're on pace to probably hit about 65 by year's end. We've deployed Narcan. We just deployed Narcan this past year, the beginning of 2016, and we've already deployed it about 36 times. One of the things that I was most proud of is our agency never had a drug drop box. And most people know what the drug drop boxes are, I'm assuming, correct? In 2016, we took back about 130 pounds of unwanted narcotics, which is pretty substantial. This year, we're just shy of 200 pounds. So that's what we're doing now as far as helping the community out in different things. Recently, we were asked to join a program that the City of New Bedford's been running for a couple of years now with recovery coaches from our agency. So we have 2 officers who are currently going through training. They're going to be doing follow-ups with individuals that have been subject to addiction or overdoses. And the way the program works is about 24 to 48 hours later, we'll do follow-ups with these individuals to see if there's anything that we can do along with clergy and then also members of 7 Hills to see if there's anything that we can do to assist them. So our dynamic's also changing. That, you know, the lockup, bail and release theory is going out the window. That we're actually seeing these people for who they are, and it's, you know, individuals that have a problem. And if there's one person in this room that doesn't have a problem, I would dare to say that I'm in a room of liars. So moving forward, what we're looking to do is just to change the dynamic of how law enforcement actually responds to addiction and overdoses, and even some of the petty thefts that we're seeing. You know, our shoplifting has just skyrocketed over the last couple of years, and the one common thread that we see going through this is that it's addiction-based. That we're seeing people stealing things that, you know, are very nominal just to try to sell them in pawn shops around the streets. So we're really trying to deal with those individuals too, and it's not always just a lockup basis. Try to find out what the backstory is. Maybe even bring them into court on a summons process with a magistrate to make a decision on, well, look, maybe just dealing with them a different way is going to be, you know, better, more conducive to what things are, you know, what things are going to lead them down the road. The one thing that I can say that I have seen is that, and this is going to endless meetings, you know, attending different trainings, reading online, is that it's always the blame game when it comes to addiction. Now, truthfully, I don't care if it's a physician, I don't care if it's, you know, the bad criminal justice system. It's really time that we turn the tables and we don't point fingers at each other, and we work together to see if we can really do something about this. I don't want to take up too much of your time because I already talked longer than I really expected to. Did anybody have any questions as far as the police department is concerned? That's great, because I'm not begging anybody. I think without further ado, I'm going to pass the microphone off to the marquee speaker, Dr. Potee.
Nancy, am I mic'd up? Am I good? Can you guys hear me? I have a thing over my ear which makes me want to break into song and dance, and you definitely don't want me to be doing that. I'm a little freaked out by this thing. Can I just say that I've been a little teary-eyed today just because I'm under stress for a variety of reasons, but I just found that so powerful, what Kyle just said. I don't know who else found that incredibly powerful too. I have to say our law enforcement and police departments in general across New England have been one of our faster moving change organizations. You know, like there are a bunch of, you're going to hear me throw a bunch of people under the bus tonight of places and social organizations that I think are not still doing enough about this epidemic. But I tell you, our local police officers have really, really flipped 180 degrees really, really fast. They've been extraordinary. And they are now frontline social workers, and there's frontline medical officers, and that's true for everybody in this room who works as an emergency responder. You guys have been the group at the very front lines of this epidemic, trying to save lives and trying to improve people's paths into recovery. And you know, I can say that in many different ways, but I can tell you there are organizations that haven't yet moved, but you guys are doing the movement. So, you know, hats off to the Dartmouth police and to the police officers in Fall River and other towns around Bristol County. I'm really impressed to hear that. So we are being very big picture today, and in fact, people towards 3/4 of the way through my talk are like, God, she's not even talking about heroin. I get there, I promise you. But this is a big picture addiction talk because addiction affects people in many different ways. And you are actually interacting with people who struggle with addiction who aren't shooting fentanyl today. They're struggling with a different kind of addiction. And I want you, because you are a group of people who want to learn more, but you're also frontline emergency responders, you see people who are really suffering in a variety of ways. So I want you to understand how it is that the brain breaks down with addiction, and understand a little bit more about some of the pathways that we might implement to make things better. So we're going to talk about the most amazing organ in the body, which is the human brain. I went to Yale Medical School, and when you go to Yale Medical School, you are taught the most important organ in the body is the kidney. It's a very kidney-oriented school, because the kidneys are quite extraordinary. But actually, the brain is pretty damn impressive. So the reward circuit of the brain is this most elemental, ancient part of the brain. Every living being on this planet has a reward circuit. And the reward circuit is the thing that keeps you alive every day. It tells you to get out of bed, find food, find water, and find a mate, because your entire purpose of being on this planet is to send your genetic material forward. That is your purpose. Now, most of us did not wake up this morning and think that way, right? I know that. However, it is, from the most elemental part of your brain, the reason we exist, to survive long enough to have the next generation, or 5 spread out ahead of us and to keep them alive so that we can populate. That is our instinct as animals, right? That's what all animals do. So this is the cover, or a picture from National Geographic. And the cover of National Geographic in September of 2017 was The Physiology of Addiction. Did anybody read it? Do you still subscribe to National Geographic? Yes, I do. Good for you. We restarted our subscription. I grew up with National Geographic. It's a great magazine. So it's worth Googling. And I'm going to pause to say this slide deck is available to everybody in this room. And when you sign up on Lisa's sign-up sheet in the back, or on Evite, she will send it to you. Is that fair to say? So you don't have to stop and take pictures of slides that you like, or even take notes, right? You can take as many notes as you want, I don't care. You can go give this slide talk tomorrow anywhere you want, and you can say you did the whole thing. Don't even credit me, just go out and spread the knowledge. But the slide deck is totally available to you, okay? So this is a great Googleable article on the physiology of addiction in National Geographic, and it was incredibly accurate. It had great video online that also supported it, but it really described how complicated the brain is when it breaks with addiction. I have very simple ways of describing it, partly because I do these talks to communities, I do them to students sometimes, but this reward circuit of the brain, the part of your brain that tells you to live and die every day, is the eat, drink, and have sex part of the brain. And it is the part of the brain that is impacted with addiction. And if I could pick up addiction and move it to any other part of the brain, the disease of addiction would be unbelievably easy to treat, right? If I moved it off to your visual cortex and you lost peripheral vision when you got addicted to alcohol, I would say, okay, you don't get to pitch on the pitcher's mound, right? You're not going to get to drive at night anymore. I'm taking away your nighttime driving ability. And then you'd probably get better, right? But instead, the part of the brain that tells you to live or die every day is the part of the brain that breaks with addiction. It is why it is such a difficult disease for people to get through. It's very challenging. The neurotransmitter, hi. This is my favorite doctor. He just walked in the room. He's a cardiologist who is a public health addiction guy. He's amazing. So if you don't know him, he's really good. The neurotransmitter that goes through the reward circuit of the brain is dopamine. And lots of us know about this neurotransmitter. We've heard of the word dopamine before. But this is the chemical in the brain that gives you this great sense of joy and happiness. And holy smokes, that was awesome. I need to repeat that behavior. That's what dopamine does. It says that was good. It helps you survive. Repeat behavior. It has with it strongly associated fine motor skills. So the reason that people say, I'm trying to quit smoking, I'm down to smoking just, half a pack or less a day. And I look at them and I say, you drink it with your first cup of coffee in the morning, you drink it with every time you get into the car. And they're like, yeah, how'd you know? And I'm thinking, it's not rocket science. But there's a part of opening up the handle of the car, unwrapping the cellophane off your package, tapping it down, removing the cigarette, lighting the lighter. There's a lot of tremendous connection between the brain and the fingers when it comes to addiction. People will inject normal saline through a syringe sometimes because there's part of that process of loading up the works, putting on a tourniquet. It's part of the process, right? And in all of our treatment programs, you know what we should be doing? We should be doing treatment for fine motor stuff. People should be, little old ladies should be going to our treatment centers and teaching people to crochet and knit, right? All of my beaters of the world should be doing projects because it's a real distraction to the brain and it helps feed that reward circuit of the brain when you're working with your fingers, right? You want to volunteer somewhere? People need that level of work. There are two behaviors associated with dopamine. One is compulsivity or compulsiveness, and the other one is something called perseveration, or my brain can't stop thinking about it. And I want you to take those two behaviors in your head, compulsivity and perseveration, and apply them to your ancestors and their survival instinct. Every day, your great-great-great-greats who are living here in Dartmouth and Fall River and New Bedford, every day they got up in the morning, and I can tell you, it is December. It was hard living here, right? It was hard. It was cold. You certainly hope that your cow made it through the winter. You hope that you had enough firewood stored away. You hope you got to kill something and that the fishing was good this year because it was hard to keep your people alive. And so every time that your brain sees dopamine, it gets this reward and says, that was good behavior, I need to continue that behavior. Your ancestors were incredibly compulsive. They went to bed at night and the last thing they thought about was how to find food and water, right? And they were perseverators. They worried about this all the time. Those are incredibly healthy behaviors when it comes to survival. Honestly, compulsiveness and perseveration, awesome. And like most of this front row, their ancestors were not good at those behaviors, and that's why they don't exist here. Your ancestors were awesome at those two things. And the problem is, part of the definition of addiction is compulsivity and perseveration. You cannot stop thinking about it. It's the first thing you think of when you wake up in the morning. How am I going to score enough money to get my dope so I'm not sick today, right? That's why you're stealing stuff and pawning it off at the pawn shop. You are desperately trying to keep yourself alive. So these two behaviors, when applied to addiction, are just a pain in the butt, quite honestly. For those of us who are forward-facing, in the trenches, Narcanning people multiple times, taking people in the ER multiple times, re-entering them into your treatment center, you sometimes look at them and think, man, this is the 50th time I've seen you this year. Why can't you get yourself moved beyond this? But if you pause for a minute and remind yourself, perseveration and compulsivity, that is the behavior that is driving them in their brain. So I make an argument here that at a baseline, we have a certain amount of dopamine in our brain. And here I'm going to tell you that on average, maybe most of us are sitting at 100 units. And some of us are the happy-go-lucky golden retrievers, everything glass half full. We have a dopamine level of 106. We're like the problem solvers of the world. People that I spent my morning with in my primary care office, they have slightly lower dopamine, right? Their baseline dopamine may be 85 or 89. It's really hard for me to convince themselves that they can make a change. They can't tell me any new ways they might try to exercise. They haven't been able to lose any weight, and they can't get off their cigarettes, right? And there's a lot of no that comes back to me, even though I'm trying to make them have little tiny pathways to change in their own mind. So we all as human individuals have slightly varying amounts of dopamine in our brain, but on average our amount of dopamine may be about 100 units. Now, there's no way to measure this. This is not a blood test. Don't call your family doctor tomorrow because they're going to think you're crazy. But when you look at this in comparison to the substances of abuse, if we're all sitting at a baseline of 100 units of dopamine, and you find that you have discovered, a 5-point stag, and you don't just have to live on cod for the next 3 weeks, you're living in New Bedford, and you kill something, you get a spike in dopamine, because you are now going to keep your family alive for another week. That is awesome behavior. Your dopamine goes up to 150, and then it goes back to normal. This is your brain trying to survive. You have sex, it's consensual, you have an orgasm, your dopamine goes to 200, and then it goes back to normal. This has been true for the 200,000 years that we have lived in a human form on this planet. It is the way it's supposed to be. When you use a drug like cocaine, your dopamine will spike to 350. When you use a strong prescription opiate, heroin, or fentanyl, or something even worse these days, your dopamine will spike between 500 and 900. When you use a drug like crystal methamphetamine, your dopamine will go to about 1,300. So what's really amazing is that most of us didn't get up this morning and take, do a hit of meth, right? That's the amazing thing. I just said I got something that's 6 or 7 times awesome sex, and most of us didn't get up this morning and do meth. Whoops. So we're going to talk about why it is that most of us didn't do that, and also how it is, again, that the brain breaks down. I'm not going to walk you through every pathway of every drug or addictive behavior, but I am going to tell you, at the end of the day, it all ends up in this reward circuit with the production of dopamine. There's 3 things in the equation for dopamine. How much dopamine is produced, how many receptors are on the other side of the synaptic cleft receiving the information from dopamine, and then the final thing are these little vacuums that come in and suck dopamine out of the active part of the brain. Cocaine is the drug that has the fastest mechanism of action. It's the easiest one to understand. It happens to be the drug for which we have no treatment. It actually never makes sense to me, because here I have a drug that actually works in one simple way. You would think it would be easy to treat. It's actually our hardest addiction to treat. There's no effective treatment for cocaine that we've ever discovered. Cocaine works, it just turns off the vacuum. That's all it does. And when you turn off the vacuum, there's nothing sucking these huge amounts of dopamine out of the synaptic cleft. And that's how you get yourself to a dopamine of 350. The opiates work in a more complicated way, because they go through the mu opiate receptor, which then goes to a negative feedback loop with the GABA receptors. But at the end of the day, every opiate makes more dopamine and forces it out into the active part of the brain. So I just told you about 2 fast drugs and how they work, but we could do this with every addictive behavior or every drug out there. Some of the pathways are incredibly complicated, and we don't actually understand them all. So when the brain has been used to, for 200,000 years, seeing dopamine levels of 85 and 150 and 200, and that's the normal, and the brain starts seeing these spikes of 350, 900, 1300, your brain says, holy smokes, something is wrong. this is an overabundance of a chemical that I shouldn't be seeing, so I need to turn down the volume. I need to down-regulate. This is your brain's response when you start to use drugs. And your brain starts erasing dopamine receptors, it stops producing dopamine naturally, and it starts turning on every vacuum in sight. That is a normal brain's response to what's not a normal amount of dopamine in the brain. So people who struggle with addiction wake up every morning and their new dopamine level is at 85 or 100, right? Their new dopamine when they wake up in the morning is 40 or 45. That is not a level that is consistent with trying to stay alive on this planet. You feel terrible. You are a miserable SOB. And it's not just because you're in active withdrawal. This is before the active withdrawal starts. You are a miserable SOB every day, quite honestly. You can't take care of your kids. You can't pour them a bowl of cereal. You can't call my office and not drop an F-bomb at every one of my office staff. You are a very irritable individual. And your brain is saying, you have got to fix this. You know how to fix this. Let's get it back to normal. You know what you're doing. Let's make it happen. Why wouldn't you go out and use again, right? It actually makes sense in many ways to go get a hit of something and make yourself feel better. In fact, what doesn't make sense and what is so extraordinary is that people are willing to put themselves through the misery of going into withdrawal, into treatment. It's really quite courageous that so many people do it because it's damn hard. So, I think of this as the broken brain, right? The brain doesn't have a fracture, but we have a disruption in the neurotransmission regulatory system of the brain. And it takes a long time for this to get better. So let's talk about what happened today in New Bedford, okay? And I can say this about any hospital, so nobody who works for that hospital can be mad at me. Don't be mad at me tonight. So this is the ER, and this is a patient that maybe came from Freetown, okay? So I have a 68-year-old guy up there, and he is the guy on the upper right. He's having crushing substernal chest pain. And his wife looks at him and says, you don't look so good. And he says, oh no, it's just a little indigestion. And she calls 911 because she's smart. So 911 walks into that living room and is like, holy smokes, this guy looks terrible. His ashen is gray, he's blue around the lips, his heart rate is a little irregular, and they give him a sublingual nitroglycerin and a beta blocker and an aspirin, and they put him in a big bore IV, and they're thinking about hanging some morphine, and this guy's looking really sick. And this is a really good cardiac ambulance. They are able to transmit this EKG to Charlton Hospital. It takes one look at that and says, don't bring him here. Like, bypass us. What's your big hospital you guys could go to? Would you go to Providence? St. Luke's. Do they do cardiac surgery in St. Luke's? No.
Actually, Charlton has the angioplasties.
Okay. This guy doesn't need an angioplasty. He needs an emergency bypass surgery. So we're going to med flight this guy out of here. I don't know. We're going to send him today. We're going to send this guy to the Brigham. I'm not going to have cross state lines. We're going to rush this guy up to Boston. He's going to need quadruple bypass because he has blockage in every artery in his heart. He's a disaster. And he ends up with this very expensive, complicated surgery, and then he ends up in the cardiac care unit for 4 or 5 days, and then he ends up on telly for another week, and then he gets depressed, a little bit of complication, and then he gets released, and he has a new cardiologist, he gets to see a primary care doctor, he goes to cardiac rehab for 12 weeks, he has a therapist because he got really depressed, all those things happen for him. How much money have we just dropped on this guy?
$250,000.
I love you. Who said that? She just said $250,000, which is what I think this guy just cost us. Do you work in public health?
I do not.
Okay, she's an awesome guesser. You bring her gambling with you because she's a guesser. Okay, so his next door neighbor in this little town where he lives is this young 24-year-old girl who's been doing really, really well. She's had 7 months of sobriety. She just got a job at Dunkin' Donuts. She's really excited about it. And that morning, when her mom knocks on that bathroom door, and there's no response, and the door is locked, the mom is very appropriately concerned. She has Narcan on her, and she busts that door in and finds her daughter lying on the ground, blue and non-responsive. She calls 911 first, because you always do that first, and she administers the first dose of Narcan, and her daughter doesn't come to. And by this time, police have arrived, and your police are all carrying Narcan. They go through both their vials they have in the cruiser, and then the ambulance arrives. It takes 5 vials before this girl comes to, right? And she goes to the same emergency room, and what is given to her there? Phone numbers? Yeah, phone numbers, right? She has acute vomiting and diarrhea. Her dopamine level is 45 because you just took her from whatever she was at, 500, she's feeling pretty good, and you just crashed her down the toilet, right? And she's sick as a dog instantly. And I'm going to give you a brochure, and on that brochure are 52 numbers that you need to call every 15 minutes to get treatment. Good luck to you, right? Bye-bye. What if she'd gone to our little local St. Anne's hospital? Anything different happened to her? Anybody know? At St. Anne's, I just learned this morning, they actually are getting a recovery coach. They come down, a peer-to-peer person who will meet you, who's been in the situation before, and who will meet you and help guide you through the system. Because people in crisis, you need to meet them in their crisis moment and see if this is a time where I can help you change. And if you think these people are going to be able to do it on their very own, it's not happening, right? We have a nurse who works at this hospital who actually is an addiction specialist. You know how many hospitals have moved this far that they are going to actually have a consult addiction service there? That's what you have here locally. That's pretty damn awesome. Because here I am saying that emergency medical responders, police, I would argue that many courts and drug courts in Massachusetts have actually moved very fast. But you know who have not moved fast to respond to this crisis? Doctors have not moved fast. They have not moved fast enough. They have not moved in the army that we need. And I will say, by and large, most hospitals in this state and most hospitals in New England are not meeting this crisis where they are. Because when you admit somebody with an arm abscess and you admit somebody with endocarditis, you are not treating the disease of endocarditis. That is a symptom of their disease, right? That is just the infection of a heart valve. Their disease is addiction, right? And if all you're doing is treating their endocarditis and getting them a new valve and sending them out to the street, you are basically saying, I'm willing to put in a second valve or else bring you to the morgue in another 6 months. Most hospitals have not done anything on this issue. They are not changing and moving fast enough, and I find that outrageous. It's the reason I do this work, is I'm so pissed off at my colleagues for not having joined this fray faster, harder, and earlier. It has to happen. So here we have these two individuals, and I didn't tell you the full story on the 68-year-old guy. Okay, he's 68 years old. Both of his parents actually had cardiovascular disease. His dad died of a massive heart attack at the age of 58. His mom had a massive stroke at the age of 72 and died in a nursing home. He smokes a pack and a half a day. He kicks back a 12-pack of beer every day. He goes to McDonald's 4 times a week. Did this guy create his heart attack? He did, right? He's 68 years old. That's it. We know he has some genetics. I will give him that credit. He had some genetics. He didn't have any choice on that. But otherwise, everything else he did actually created his cardiovascular disease. Did anybody wag their finger at him in his living room, the EMS workers, or in the emergency room, or to bring him and say, you know what? I actually think I'm not going to provide any care for you because you're an addict, right? What's he addicted to?
Cigarettes.
Nicotine, yeah?
Alcohol.
Probably alcohol, yeah, absolutely. What else? Fat and sugar, right? This guy is not leading a healthy life. We did not look at him and say, you know what, you're making terrible choices with your life. Terrible choices. You're costing me $250,000 today. Why would I invest in you, dude? You may even go back and just smoke again and drink again. Forget about you. I'm walking out of your living room and you're just going to have to, you can just pass away right here. Save us some money. Nobody did that, right? That would be appalling medical care. Yet we choose to do that with people with an opioid use disorder every single day. And if we're going to treat people equally, then, start judging everybody equally, right? I'm going to fire all my patients whose hemoglobin A1C is over 9, and you haven't lost your 10 pounds. Well, shame on you. I'm going to make you feel terrible. I'm going to kick you out of my practice. I get paid by how good my numbers look, right? That's actually how I get paid these days. And the fact that I have a bunch of unhealthy people that I take care of, I should fire them all, right? I should just take care of the marathon running vegans, and then my numbers will look good, right? But I would be the worst doctor on the planet. I also have to do my job. And my point is that in the medical profession, whatever angle you come at it from, our job is to actually start treating people fairly and equally. That's my attitude. And if anybody in this room is in the medical field, I hope that you're going to change your mind about taking care of people who struggle with addiction. These people need help more than almost anybody else does because these people are at high risk of death. And they cost the medical system a lot of money. Okay, let's go back to dopamine. That was my little throw the medical system under the bus because I find that whole thing outrageous. So this is a little slide that reminds you that I didn't make up the dopamine story. These are PET scans that are measuring dopamine in the brain. And dopamine on the slide is the orange active part. And what you see in that middle column are healthy brains of people who don't have addiction. And then what you see in that right column are people who struggle with addiction. And that top slide is cocaine, the next one down is meth, third one down is alcohol, and the final one is heroin. I like this slide because it reminds me I didn't think of the dopamine part, but also because I like to look at that alcohol brain. There's still a surprising amount of active dopamine in people who struggle with alcohol. I will argue that alcohol is one of the most harmful substances in our society. It causes tremendous devastation to individuals, to families, to communities. It's expensive. You know, my little local jail, half my people there are locked up for alcohol use disorder, right? I'm not going to minimize the impact that alcohol has, but the wheels come off the bus with alcohol use disorder late in the game, right? Before your wife walks out of you, you lost your job, and you've got your third OUI, you're a pretty functional alcoholic. You may be a jerk, your kids may not be talking to you, right? You may wake up and not be the best you can at your job every day, but really people function as alcoholics for a long time before they acknowledge or recognize or are forced into getting treatment. Lots of us in this room have family members who struggle with alcohol. So let's talk about what happens, what it takes to develop the disease of addiction. And I make an argument in this talk that there's really three things that play a role. There's many, many things. I make it a little simpler, but three things. The genetics, early exposure while the brain is developing, and a history of trauma. Having poor mental health does not create addiction. Being a 15-year-old anxious boy does not make you a future addict. Being a 15-year-old boy who realizes that when he drinks, he's really funny and he has friends and he's the life of the party is a 15-year-old kid who has early exposure while the brain is developing, right? So poor mental health is a subcomponent of everything else. It can be a subcomponent of the genetics of the early use or having trauma. So the genetics of addiction are unbelievably powerful. It's very hard to find any disease that has as much genetic implication as addiction does. So if you have a parent or a grandparent with addiction, you have about a 50% chance of developing addiction yourself. So who needs to hear that piece of information?
PCPs, doctors.
Right, you need to share your genetic history with the people who are caring for you, yeah? But who else in your family might need to know that? Your kids. Right? And this is actually an uncomfortable conversation, I think, for many people when I say, actually, you guys should talk to your family members about your genetic risk of addiction. The reason I say it is because it seems a little bit hopeless, like I'm asking you to do something that our kids can't fix. You get what you get with your genetics, right? You don't get to change that. But the truth is, our kids need to understand what their genetic risk is of addiction because they actually get to make a choice that over time almost cancels out the genetics altogether. So the reason we must talk to our kids when we have a strong genetic history of addiction is our kids can actually influence something so that the genetics actually disappears. That's why you talk to your kids. And when I sat down with my three kids to talk about our strong genetic risk of addiction, I didn't tell them the who's, the what's, the exact details. I just said we have a strong genetic risk. It puts you in harm's way. And you can choose to avoid this in the following way. So what we know about all addiction is that it is a developmental pediatric disease. All addiction starts while the brain is developing. So when you talk to somebody with addiction and you ask them, how old were you when you had your first use of alcohol, marijuana, or cigarettes? What do you guys think the answer normally is? I love you guys. You're like the smartest people I've ever talked to. The answer was 12, 13, or 14. I would say those are the average ages I hear. I was 12, 13, or 14 when I started one of those three, what I think of as the three easy, most likely starts, okay? If you postpone your use of any addictive substance till after the age of 23, 24, 25, you won't develop addiction. You just won't. Really, it's like less than 1%. You need to postpone your use until your brain is as close to fully developed as possible. That is why your kids need to understand what their genetic risk is, because they get to control that one 100%. That is actually on them. So when you look at, and so you guys gave this answer of 12, 13, and 14. For those of us in the room who know people who started a lot earlier, or when you ask this question of people, let's say in a jail, people who are really, really struggling with addiction, in that room they'll say, I was 6 when I started. I was 8 when I started, right? Those are numbers that I find appalling. My heart breaks every time I hear that. But I get those answers all the time too. So if you are a 15-year-old kid and you start drinking, and drinking is defined here as 2 alcoholic beverages a week. Right now, a half kegger, 2 beverages a week at the age of 50. 40% of those kids at 15 go on to be alcoholics. And if you wait until age 21, 7% go on to be alcoholics, which is about half the rates of today's current rates of alcohol use disorder. I'm not sick, I'm just talking. So again, when I talk to my own kids, the message I say to them is that you need to delay your use. You cannot be the 17-year-old who goes to the post-football game and starts drinking with your red soda cup. You can't do it because your genetic risk is too high. You need to postpone your use. I don't ever want you to smoke cigarettes, but you need to postpone your use of alcohol and marijuana until your brain is as close to fully developed as possible. Now, I recognize that's not realistic, right? You launch your kids off to college and you have no idea what they're going to be doing. But you try to give them as much information as possible to help them make good decisions. Okay, so let's dive in on something that I'm not going to understate today. We're going to pay attention to it because although this isn't maybe exactly what you guys are going to be doing in the emergency responding system, this is sort of what's going to be happening to us in the next 10 years, and I think we have to be very knowledgeable about it. When you ask a 15-year-old kid, do they smoke? I do this all the time because I'm a family doctor. They look at you like you have 3 heads. And they're like, of course I don't smoke. And then I say something like, oh, like, what do you think about cigarettes? And they're like, cigarettes are disgusting. That is what most teenagers say these days, right? I grew up in the 1980s. I went to high school in the 1980s. We smoked in high school. Like, we were smoking in the hallways in Western Mass. The teacher's lounge was the smoking lounge, right? That wasn't so long ago. When I tell my kids that happened in school, they look horrified. They can't imagine that people smoked in high school. They're disgusted by it. The sense of harm with cigarettes for teenagers is really high right now. But the problem is, and the good news is, as the sense of harm goes up, the use goes down. The problem is that the sense of harm with marijuana is really low right now, really low. So what do teenagers say to us, or people under the age of 25? What are people's beliefs about marijuana?
It's better than doing hardcore drugs.
It's better than other drugs. In fact, it's better and safer than alcohol. There's often a comparison directly with alcohol. What else? It's an herb, it's natural, it's organic, it grows in the ground. I don't want anything from the pharmaceutical industry. What else? It's not addictive, right? Yep, I heard it's legal. So far, that's the first one that somebody said is true, right? It is legal. What else? Anybody have any other ideas what comes at you?
Nobody's ever died from marijuana.
No one's ever overdosed with marijuana. You get that one all the time, yep. That one's actually not too far off. There have been a couple of cases of deaths associated with marijuana in Colorado, but that's because people became psychotic and they jumped out of buildings. There was a man who shot his wife because he was psychotic, because people can get psychotic. You guys have covered almost all of them. There's one other one people say. They'll say it helps me. It helps me sleep. It helps my anxiety. I've had kids say to me, I'm better doing my homework. I'm a better athlete on weed. I'm like, no way you're not, right? There's no sport where having slowed reflexes is a positive thing. Okay, so we're going to talk about marijuana because this is our very near future, and you're going to kill me because I'm going to spend time on marijuana. Are you guys going to kill me? I have to spend this much time. We got to do this, okay? Because marijuana is. You guys just had a big vote on marijuana, right? New Bedford did. What was that, Lisa? Did it happen, the New Bedford vote? It's happening next week. Anybody know? Okay. Well, so I think something's happening here. Okay. So the brain. This is the way the brain develops. 3 critical things happen during adolescence. Between the ages of 12 and 24, 3 things happen, some of which don't happen any other time. And the first one, and this is the one that happens really in no other time other than between the ages of 12 and happening in this building right now, is something called synaptic refinement. In your head, you have tens of billions of connections, and you do not need that many. And in fact, having that many is harmful. You need to prune it back. That time, the adolescent period of time, is about cutting back connections that are no longer helpful and making better decisions about what you want to keep. There are times during adolescence where you are losing 30,000 connections a second, right? You never get to do this again. After the age of 24 or 25, your brain is done, right? And in fact, all it's doing then is just getting shrink. It's just atrophying after age 25, right? The rest of our brains are just getting older and slower, and we're losing memory. So the other thing that's happening during this age is something called myelination, where you are making fast pathways in the brain. So you're ensheathing, you're making more efficient pathways in the brain. So these brains that I'm talking about of our kids that we have in our schools or we have here at UMass Dartmouth or that we're raising in our own houses, these brains are actually totally normal. They're actually awesome brains, even though they make us insane. I have 3 teenagers. Oh my God. They make me insane sometimes. And I remind myself all the time that what they're going through is totally normal. And what they're doing is very normal. They act first, think later, more risky, impulsive behavior, less than optimal planning, less consideration for negative consequences, strong preference for physical activity and sensation seeking. There's never a time in your life when you're more influenced by your peers, ever. There just is not a time. And I want you to pause on that from an evolutionary standpoint. By the time you were an adolescent anything, an adolescent lion, an adolescent any animal, you had been booted out of the tribe, right? You were another mouth to feed. You were actually another thing to compete with. You were gone, right? And most of us aren't booting our 13-year-olds out the door, although there are days I would consider doing that. But this is a time, in terms of evolutionary speaking, you have got to find your people, right? This is about finding your herd. And what we all know, for those of us who interact with a lot of teenagers, who their peers are influences how they are, right? And you should know your kids' friends and know their parents and do everything you can to sort that out, because you sort of hope they end up with a good, healthy crowd. So there's never a time where you're more influenced by your peers. And I want you to pause and think about that. When you were in 2nd grade on the playground and a buddy said, let's go do this stupid thing, and you're 7 years old, you're like, no, it's stupid. I'm going to go tell the teacher. And when you're 27 and somebody says, let's go do this idiotic thing, you're like, dude, you're an idiot. Like, I don't want to hang out with you anymore. But when you're 15 or 16 or 17 and somebody says, let's go do, you're like, yeah, I am in, right? This is the nature of the brain. There's nothing wrong with this brain. It is doing what it's supposed to do. It is pushing the envelope. These brains are trying to sort out what needs to stay and what needs to go. So we need as many positive things coming our adolescents' way as possible, right? We need to keep these guys busy with all kinds of positive activities and surround them with loving, supporting adults and have them not have as much trauma as many of our teenagers get. So I said there's 3 things that happen. I only told you about 2. The third is that we lay down receptors in the brain. The final dopamine receptors get laid down in the cortex of the brain. And that is why all addiction is a pediatric disease. You understand already how dopamine is impacted with addiction, and I'm telling you that that's when the final dopamine receptors get laid down in the outer shell of the brain. That's why it all develops while your brain is developing. There's another receptor that gets laid down during this time, and this receptor is called anandamide. And anandamide is a receptor that we didn't know about very much until in the last 20 years. This is a receptor that is a naturally occurring endocannabinoid. And the problem with it is the mirror image of THC, which is the psychoactive cannabinoid in marijuana. Your brain is unable to differentiate those 2 things. It cannot tell the difference between THC and the naturally occurring anandamide. And here I have a chemical whose job it is to help determine what is cut and what gets kept. And then I introduce THC, which is like a sledgehammer, because it has much more attraction to this naturally occurring receptor in the brain than our own naturally occurring one. So I now have THC in the developing brain that is making terrible decisions about what stays and what goes. This is the reason why I spend time on marijuana. Because what anybody in this room does after the age of 25 with pot, as long as you are not driving, putting another human being in harm's way, babysitting my kids, operating on my knee, as long as you're not doing any of that stuff and you're in your basement smoking pot over the age of 25, I don't care. I actually don't think it's any worse than alcohol when the brain is fully developed. But I think that THC in marijuana is a neurotoxic substance while the brain is developing, period. And I'm going to show you some slides to try to convince you of that too. So what we know is that there are deficits in cognitive function, there's an impact on attention, verbal learning, memory, processing speed, and that stays even when you're not high. It continues on. When you look at outcomes, and so this is going to compare, this is a study that comes out of New Zealand, and it's going to compare 2 categories of people. I'm going to use the 2 extremes just to make it very clear. The light blue line are individuals between the ages of 15 and 21 who use marijuana 0 times, okay? And then I'm going to compare it to the other category of people, individuals between the ages of 15 and 21 who used marijuana 400 times or more, which may seem like a big number, but it doesn't take much to get to 400 times. That means you're using it every other day, right, over a period of 6 years. It's not that much. I have kids in my practice who smoke weed 6 or 7 times a day, right? They wake up, they take a hit, they're smoking at 11 o'clock, they're vaping it in the bathroom right now, they smoke at 2:30 when they get home, it helps them play soccer or whatever it is they're doing, right? They do it before they go to bed. Marijuana use has become ubiquitous, and the daily user has become very, very common. So when you look at people who use 0 times versus people who use more than 400 times while their brain was developing, the college graduation rate by age 25 for the 0 use is about, I don't know, 33%. The college graduation for the 400 use or more is 18%. When you look at unemployment rates of those 2 categories, unemployment rates for people using 400 times or more is approximating 45%. Right, compared to kids who didn't use, where the unemployment rate is around 18%. For me, this is a kid who's failed to launch, right? This is a kid who's still living in my basement, and I love my kids. I want them to go to school and leave me and be productive members of society. That's what I want for my kids. So this is the concern I have about marijuana use in adolescents. There's a very good evidence about drop in IQ, and this is, again, data looking at teenagers following them up to the age of 40. And this shows an 8-point drop in IQ by the time you hit 35. The problem with all of this data is it's based on the old marijuana. It's based on THC levels of 3% or less. There is no marijuana out there with 3% or less anymore. That is an old seed that is stored in somebody's seed library somewhere. Because every field-grown plant of pot out there now is sitting now between 9 and 16%, right? That's what's being grown. And every year, it gets stronger. I live in the agricultural center of Massachusetts. We got pot plants growing everywhere. And I'm telling you, the stuff they're growing is more and more potent. The other thing is when you start to look at the concentrates, this is what we think is of the crack of marijuana. This stuff is ranging between 50 and 90% THC. And so for those of you who aren't spending a lot of time with pot these days, this is what our kids think of when they think of pot, right? If I saw this in my kid's bedroom, I would be like, ew, what is that, right? They call this stuff earwax, butter, shatter. It looks disgusting. But it is a really potent product that you can vape and smoke and cook and do all kinds of things with. And if you think your IQ is dropping by 8 points only with this stuff, it's dropping by a heck of a lot more. I'm describing a neurotoxic drug that is more and more potent. So you guys know this already, but the marijuana these days comes in all kinds of forms, and you can vape it and smoke it, and you can eat it, and you can eat it in ice cream and milk and spaghetti sauce. You can rub it on a cream. You have tinctures that go under your tongue. There's many, many ways to get this into your system. And then what we know is that when we passed this bill in Massachusetts, we were very specific with this bill that was clearly written by the marijuana industry that they had to be able to sell edibles, right? There was no limit of THC that would be sold, and in fact, the bill is very specific that stores should sell edible products. This stuff is targeting our teenagers, right? This is stuff that is marijuana mixed with fat and sugar in candy bar form and cotton candy form and gummy bear form. This is stuff that directly comes from Colorado. When you look at those candy bars, there are 12 servings of marijuana in there. So the last time that anybody in this room shared a Kit Kat with 11 other people was never, ever in your entire life, right? So here I have every candy bar with 12 servings, and the THC content in every candy bar you're seeing up there was 80%, right? So that is a very worrisome trend that will be coming to a store near you. And again, what happens over the age of 25, I don't care. You guys, you can't go into a marijuana recreational dispensary if you're under the age of 21. I think that rule will be upheld. But I have a medical marijuana dispensary in my local town, and I can tell you those medical marijuana products are dispersed throughout the high school. Right? You have to be 21 with a card to get in there. But that doesn't take much to walk out of that store and hand it off to a teenager at Northampton High School and have them spread it around everywhere, right? So these products are targeting our kids because if you had a business whose job it is to sell an addictive product, your job is to addict as many people as possible, right? That's what the alcohol industry does, that's what the cigarette industry used to do and continues to do, and that is what the marijuana industry will do. So let's talk about the fact that lots of people think this is not an addictive substance. So when you talk about the most addictive substance out there, the answer is really sugar, which is the most addictive substance out there. But the second most addictive substance out there is tobacco, right? It's very, very addictive. But we used to always say that marijuana was 9% addictive if you start when you're an adult. Now, we still say that, but the problem is that if you start when you're a teenager, the rate of the addictiveness of it is closer to 18%. And the problem is that once you get to daily use, the addiction rates now are closer to 25%, which makes it more addictive than heroin. That is not a positive thing. And again, the data on the addiction rates that we're dealing with is with the older THC products, right? I'm not even talking about these higher THC. So people who think this is a non-addictive drug, that is simply a non-truth. What kills me about this is I'm a public health person, right? I got a lot of public health people in this room. We have done this before. We did this with tobacco, right? We grew up in houses where people smoked. We grew up in high school where people smoked. The #1 killer in our country is tobacco by a long shot. We allowed the industry to sell a product that got more and more potent. They wrapped it up in paper, and by the year 1950, 70% of American men were smoking cigarettes. That was the nature of the beast. And we have just handed the new industry over to people who want to make a lot of money on the backs of people who are going to develop addiction. I just don't think this is a positive public health move. Right? You have cancer, I'll certify you for medical marijuana, happily, right? But this is going to be targeting our teenagers. So I don't know, it seems to me like nobody in the room knows what is happening in Dartmouth with a medical marijuana dispensary. I mean, a marijuana dispensary, not medical, but do you guys know? Yeah?
There is a dispensary that submitted a special permit application.
In Dartmouth?
In Dartmouth, so I think there will be one.
There will be one. So the town has not voted it out, and in fact, there's already a permit for one coming, is what I'm hearing? Yep. It's fair, they just did what? They just approved the dispensary. Okay. In lots of towns on the Cape, Barnstable is the biggest one I can think of right now that also just approved. And I tell you, New Bedford is in the news right now. There's a vote coming up. Right? You agree with me on that?
They have a letter of non-opposition from the dispensary.
So what Cheryl just said is there's a letter of non-opposition to a dispensary, which seems like a letter of support as far as I'm concerned. So guess what? Lots of recreational marijuana stores coming to you, right in this region. They'll be chock-a-block. Okay, let's move to alcohol, because I said earlier that alcohol is a problem. And you guys know this is a problem because lots of us have family members who struggle with alcohol. So when you look at the numbers nationwide, 1/3 of us drink absolutely nothing. And 1/3 of us drink a tiny amount of alcohol. A drink a week, a couple drinks a month. We're very light social drinkers. And the final 1/3 of us drink everything else. Everything is us. And in fact, the final 10%, possibly the final 12% of us in this country drink on average 9 to 10 drinks a day. That's a lot, right? And most of those people aren't here, because if you're getting 10 drinks in, you've already started drinking. So this is the problem. Every day I spend my day taking care of patients in an outpatient clinic, and I ask all day long, tell me about your relationship to alcohol. And people will say, oh, I have a couple drinks. Mainly women, in fact, will say, I have a couple drinks at night. And I say to them, what are you drinking? And they'll say, I drink wine. And then I'll say, well, how much are you drinking? Because people don't understand what it is to get to a drink. So I have become a very moderate drinker, and I'm not going to tell you I've ever been a heavy drinker, but I am much more conscious of how and when I drink now. I am not a 5% alcohol beer girl. I'm a locally made, brew, hoppy, 6.7% alcohol beer, right? Those beer bottles are all 16 ounces, and at 6.7 or 7.2% alcohol, I easily get myself to 2 drinks with a single beer, okay? So you got to look at the math on how to add things up. A drink of wine is 5 ounces. Hard alcohol is 1.5 ounces. So when you ask a woman, what's your relationship with alcohol? And she says, oh, I have a couple drinks at night. And then I say, well, how much is going into your giant wine goblet? They have no idea, right? And I say, you know what? I just need you to put 5 ounces in that glass and just eyeball that line. I just need you to acknowledge what you're drinking every night. No shame, no blame on my part. You need to know what you're drinking. Because my worry for you is I actually think you're probably drinking 3 or 4, possibly even 5 glasses of wine every night, by anybody's definition. And that, by anybody's definition, is too much alcohol. So today's world is really changed in terms of alcohol consumption. It was not the case that women used to drink, and I tell you, women drink like fish now, right? It has become marketed to women. It is the new norm for women. You never go out with your girlfriends that you're not drinking. Very few of us ever go to an adult party where there's no alcohol involved, right? A lot of alcohol involved. This is the norm. And don't get me wrong, I drink, right? Like, I'm not somebody who doesn't drink anything. I'm very aware of how I drink. One of the problems is that as adults, we have normalized the consumption of alcohol so tremendously that we walk in the door after a terrible day at work, and the first thing we do is we uncork a bottle of wine, we flip the top of a six-pack, and our kids see the response that we have. You have a bad day at work, you should drink. You're feeling stressed out and miserable, you should drink. That's the message you send to your kids. And instead, we should walk in after a terrible day at work and say, man, I've had a bad day. I need to go for a walk. Anybody want to go for a walk with me? I hate my job right now. I have John Kabat-Zinn downloaded on an app on my iPhone. I'm going to go listen to a 15-minute meditation in the other room. Anybody want to join me? What if we actually demonstrated healthy ways of dealing with stress in our lives? Because if you think your kids, your students aren't watching every move you make, you're wrong, right? So I'm telling you, alcohol is not a positive thing. I'm a doctor and I have a cardiologist sitting to my left. The data that we have that alcohol is cardiac protective is pretty weak data. I think it's all been funded by the liquor industry. The amount of alcohol you should probably be drinking to help your heart is a tiny amount. It is not a half a bottle of wine every day, which is what many of us are drinking. Okay, I said there were 3 things that put you at risk for addiction. The first one was genetics, the second was early exposure while your brain is developing, and the third one is a history of childhood trauma. So in this room, who knows or who uses an ACE score? Who knows about ACE scores? Great, I have people, I love that. What do you guys do? No, you're my ones. You guys know ACE scores. Are you therapists? Are you counselors? Say it again, school. You work in a school? That's it. Awesome. Okay, so this is a study that came out in 1996, and it came out of Kaiser Permanente in San Diego. And it was a study done in an obesity clinic, because when I was training at Boston Medical Center and I was working in the gastric bypass clinic, I worked with a surgeon, and the surgeon said to me, everybody you see today, and these were morbidly obese people, their BMIs were 50 or higher. Every person, every woman you see today will have a history of sexual abuse. And I was like, really? And they said, absolutely. It was sort of what we were taught. And was it true? Maybe it was true. But it was an obesity clinic in San Diego that tried to dig in on this data because it was sort of the folklore that went around with it. So this survey asked questions to 17,000 adults about what might have happened to them in their household growing up. And nobody's going to be able to read this, so I'm going to read it to you. I'm going to turn my back to you. I'm sorry for that. When you were growing up in your first 18 years of your life, did a parent or another adult in the household often or very often swear at you, insult you, put you down, and humiliate you, or ever act in a way that made you afraid you might be harmed? Did a parent or another adult in the household often or very often push back, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Did an adult or person at least 5 years older than you ever sexually abuse you? Did you often or very often feel that no one in your family loved you, thought you were important or special? Your family didn't look out for each other, feel close to each other, support each other. Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Were your parents too drunk or too high to take you to the doctor if you were sick? Were your parents separated or divorced? Was there somebody in your household who was incarcerated? Was there somebody in your household with major mental illness? Was there somebody in your household with a substance use disorder? 10 questions, yes or no? This study is a measure of neglect, abuse, and household dysfunction. And what was not known when they originally did this study is that this is actually a predictor of who is going to struggle with chronic disease. If you score a 6 or higher on an ACE score, you will die 20 years earlier. If you score a 4 or higher on an ACE score, you have 4 times the rates of heart attacks, emphysema, asthma, multiple broken bones, multiple sexual partners. And I get these looks coming at me quizzically, like, how does emphysema have anything to do with growing up in a household that really sucked growing up, right? When you are a kid living in a household where you're living in fear for your life, when you're worried you're going to come home from kindergarten and find your mom overdosed in the bathroom, when you have a brother who's sneaking in your bedroom at night and molesting you, When you are a kid whose fight or flight response is on 24 hours a day, 365 days a year, that is considered toxic stress. And that toxic stress produces chemicals in the brain that impacts the formation of every cell in your body, every organ in your body. It has a huge impact. And it's one of the greatest predictors of who is going to struggle with addiction and who's going to struggle with the disease of chronic pain. And I spend time talking about childhood trauma because nobody gets to change what happened to them as kids. But I consider an ACE score to be a vital sign. When I talk to my patients and I have their blood pressure and I have their respiratory rate, I often spend time digging in on this stuff here. Because when I have somebody who's failing with their diabetes care with me and I cannot help them change their depression, I've tried absolutely everything, I stop and think, I am missing something with this person. I am not really understand what is happening. And I take out a piece of paper from my drawer and I hand it to them. And in that room, in 3 minutes' time, I actually discover 1,000 things that I never ever knew about a human being I've taken care of for 9 years. And they often break into tears and say, no one ever asked me these questions before. And I say to them, none of these things should have happened to you. I scored a 1 on a score. My parents were divorced when I was a teenager. Otherwise, I had a magical childhood. But when I look at people who are scoring incredibly high, it helps me understand how they got to this place, but more importantly, it helps me determine the treatment that they need to get better. Because trauma does not respond to typical talk therapy. It is actually not the right treatment, right? There are very specific trauma-informed therapies for people who experience it. And if I were to suggest one thing for this part of the world in the next 10 years for us to get good at, I can guarantee I grew up in a part of the world that looked a hell of a lot like New Bedford and Fall River. I grew up in what was called the North Quabbin part of Massachusetts. It was poor, there were no jobs, all the factories shut down. It had the highest pregnancy rate in Massachusetts for 20 years. The ACE scores in the place I grew up were through the roof, and I guarantee you the ACE scores in this region are through the roof too. That's just the way it is. Yeah.
At what age?
This is a survey that is administered to an adult, reflecting on their childhood. There are surveys that are intended for kids. There's a long one that comes out of Los Angeles, whose name I can't remember right now. So these are not administered to kids, but I'm going to tell you, you know who knows ACE scores? Teachers know the ACE scores of their kids. School nurses know the ACE scores of their kids. They always know a little less of the number, right? They actually don't know they're being sexually abused most of the time because that's a mandated reporting, right? But when you ask the average school nurse about why a kid is struggling, she can give me these numbers. Lots of people who are paying attention to their kids in school know this stuff. So if there is one thing in the next 10 years that I think could shift things in this community and many other communities is to become what we call a trauma-informed community, having trauma-informed schools, having trauma-informed police departments, right? This stuff has a huge impact on how every single one of us. It is one of the biggest predictors of chronic disease and unwellness that we have ever seen. And this is the kind of thing that community health centers can really focus on because this is a game changer. The other thing we did in Greenfield, which is where I live and work in Franklin County, is we realized our treatment providers didn't know what they were doing when it came to trauma. And this is 5 years ago when we began to call them and say, look, do you understand what this is? Most treatment providers have never heard of this. Do you understand what this is? Do you understand the right treatments for this? Can you go do some training so we can send our people to you because we need help? At this point, every single one of our mental health service entities in Franklin counties are gotten really, really good at trauma. They know what they're doing. They're doing EMDR, they're doing EFT, they're doing tapping, they're doing trauma CBT, all these letters that follow this stuff. So that would be one big thing I would say could impact this disease in a way that is a little outside of the way you guys normally think about it. Okay, so the final message I'm going to say, I'm not done, even though you guys may want to leave me, or you can't leave me yet. There are 3 things that will predispose you to addiction: genetics, trauma, and early exposure. And when I talk to a group of parents, my message to them is to talk to your kids, right? If you start talking to them in 10th grade, what's a 10th grader? That's a 16-year-old. People start using when they're 12 or earlier. You start talking to your kids early. You start talking to them in the 5th grade. You talk to a kindergartner about never picking up a pill because all pills are dangerous to a 5-year-old. You find a pill, you get an adult. You don't touch it, right? These are messages you give to our kids. When I walked in my house like 7 years ago and I had a lock and I locked up the cabinet and I put all my alcohol in it, my 3 kids looked at me and they're like, Mom, what's up with you? Do you not trust us? And I was like, no, I don't trust you.
You're a teenager. Why would I have my alcohol be sitting in an unlocked cabinet where any one of you can get it? Here I am telling you, you can't expose your brain while it's developing to this chemical that causes you harm. Why should I make it any easier for you, right? Under lock and key. I know I sound like I'm a crazy mom. I'm actually not a crazy mom. I'm sort of the anti-hover mom. But when it comes to protecting my kids, things like the fact that Dartmouth police have a police take-back box, man, if you guys have pills in your house, I'm talking to a group I know doesn't have pills in their house. But anybody out there that's still holding on to some Xanax or some oxycodone from their knee surgery, if it is not under lock and key, then shame on you. It either belongs in a police take-back box or it's under lock and key, right? You shouldn't be holding on things for a rainy day. I am going to say this one other thing, which is that, yes, cigarettes are down, but what is not down is vaping and e-cigarettes. That is actually a place where we're seeing a lot of spiking use. This is an article that was in the Boston Globe maybe 3 weeks ago. And it wasn't talking about this region, it was talking about Metro West Boston, where there's a lot more money. But does anybody know about these things? Jewels, right? Do you guys see Jewels? You'll see Jewels at UMass Dartmouth, guaranteed. Are you getting some head nods? Okay. So this is an example of an e-cigarette out there. This stuff is not cheap. It's $49. Every one of those little tiny cartridges, which look just like a USB port, it's exactly what it looks like. In fact, you can recharge it on your computer, and when you drop it in 10th grade, your teacher will pick it up and hand it back because she thinks it's just your thumb drive. That every one of those things is equal to a pack of cigarettes. So our kids are actually e-cigaretting this stuff all the time, and now what are we doing? We're getting them addicted to nicotine. How is that a positive public health move, right? And where are they getting this stuff? The internet. So this is not a positive thing, it's another direction that a lot of our college kids are going in right now. So if you see anything that looks like this, be able to identify it. Each one of these Juul pods is equal to 1 pack of cigarettes or 200 puffs. And most teenagers don't know it. Look at the flavors. Fruit medley, creme brulee, right? Again, the cigarette industry is on its way down, they're trying to find a new product. I am going to say this to you guys. I have to say, this generation that we all are raising, I mean, who else is raising a teenager in the room? Anybody else? Oh, a lot of us, right? This thing, that little glow device that is glued to their palm, man, this is a hard generation to raise because many of them have gotten completely, dependent, but possibly addicted to their phones, right? It is really hard to have a conversation with your kid because they're tapping and that blue light is coming back at them. This generation is having a really hard time connecting to real human beings and having real conversations because they're like this with their phones, right? It is a generational shift, and I'm not one of those people that says the kids these days are doing it all wrong. I actually think our kids are making some of the best decisions we've ever seen. I am going to say that I am worried about the amount of screen time and device time our kids have. This generation is known as the I generation. The generation of teenagers now have never known teenagehood without a phone in their hands. This is a great article that was in the Atlantic Monthly in September. It was in the Atlantic. It's worth, again, you're going to get the slide deck so you can go back and read this article. It just talks about what these devices are doing to the brains of our teenagers right now, and it doesn't feel very good for those of us who are worried about them. Okay, I told you I was going to get to opiates, and you guys are almost done because I know people have got to go home, but I'm a normal family doctor. That's what I do. In fact, if you had asked me 10 years ago what I did, I took care of pregnant women and I did deliveries and I was a specialist in infant care. I'm really good at pregnancy and reproductive health issues. But I trained at Boston Medical Center, the old Boston City Hospital, and when you train at that hospital, you get good at all addiction because we took care of a lot of people with addiction. In fact, my favorite patient I ever took care of was from Taunton. I'll never forget him. He was an IV drug user, and I'm quite certain he's no longer alive because he was pretty sick, but whenever I drive through Taunton, I think of this favorite patient of mine. My iPad's not working. At least the screen is off. How about this, Nancy? I'm going to have you flip for me, and I'll tell you when to flip, okay? But don't flip yet, okay? I'm going to put my iPad down. I've never done this before with an iPad. I usually have a clicker, so it's been a little bit weird to interact with it. So every morning I wake up and I drink my coffee, I walk the dog, and I read the newspaper. And the first thing I read every day is I read the obituaries. Not because I'm morbid, because I'm a family doctor that takes care of a lot of people who are dying. I have a lot of old people in my practice. And I read the obituaries, I need to know who died, I need to call the family, I need to write the death certificate. And in the morning of December now, 6 years ago almost, 2012, I read the obituary of the young woman in the red jacket, the red city year jacket on the top left. And her obituary read, Ashley Sims, age 21, died of a heroin overdose at home. And I thought to myself, I know her family, I know her grandmothers, and I called them to tell them how heartbroken I was about Ashley's dying, but also to thank them about telling the truth about how Ashley had died, because it was 2012. And for several years, I've been reading obituaries of young people dying unexpectedly at home. And I live in the middle of nowhere. I know everybody. I grew up out there. So I often knew how they died, but it was the first time in my little local paper that the truth was being told. And those two grandmothers went to the Greenfield Recorder and said, our young people are dying, our people are addicted, and you need to start telling the story about what opiates are doing to our community. And so starting in the beginning of 2013, the little Greenfield Recorder began running front page stories every day on the epidemic and how they affected the schools and the courthouse and the jails and what we were going to do as a community to respond. And so this little Franklin County, which is the poorest and most rural county in Massachusetts, has really led the effort in terms of the epidemic. And lots of people for a while have been following us. Now there's a lot of communities out there who are doing great work like you and are surpassing us, which makes me really happy. But after this is when I became really involved in this effort. There's no doubt in my mind that pills are on the hook for this original epidemic. 20 years of overprescribing opiates in our community did not serve us well. When you look at us compared to every other country in the world, that top line is in the United States. That is how many opiates we prescribe in comparison to every other country in the world. If you think they don't have pain in Sweden or New Zealand, of course they do. They just have other ways to go about it. When you have a single-payer Canadian health system in Canada, you get 2 massages a year. It's part of the deal of the Canadian health system. So you throw your back out. Well, who was throwing their back out in the room? Lots of us. You call your massage therapist and you get it fixed up, right? How nice is that? And you don't launch down this pathway. So you guys know this stuff. I'm not telling you anything you don't know. At this point, we have surpassed motor vehicle accidents. We have surpassed gun violence. We have surpassed AIDS at the peak of the AIDS epidemic. That is, we are losing 91 Americans every single day to opiate overdose. By some government statistics, the number is closer to 130 people a day. And it was said earlier by our great detective that, yeah, it feels like maybe we are actually slowing down the pace a little bit, but I was talking to Cheryl Bartlett, who used to run DPH for state of Massachusetts. I don't think we actually have decreased the disease. I think we have more saves. I think more people are surviving because great places like Seven Hills are getting Narcan into everybody's hands. Our police officers are administering it. You heard how many saves Dartmouth had this year. So I think we're trying to keep people alive, so fewer people are dying, which is an awesome thing. But that does not mean that the disease is getting better and fewer people are addicted. Yeah.
I just have a question because when I think about, because I've been working in the field of substance abuse for almost 20 years, and when I think about the deaths, like a lot of people have died, they've been dying since I've started.
Yeah.
But is there any truth, and maybe you know this, is there any truth about the change in the source of the heroin that's causing this drastic spike in overdose deaths? Because, like, you know, when I first started out, like when someone would die, I would be like shocked and appalled, and I'm almost at the point where I'm desensitized to it, but I'm not. But like and I read this article about the change in the source of the drugs and how that's a big.
We're going to talk about that in a few more slides. Absolutely, huge difference in that. So when you look at death rates, it starts on that map in 2003. The red are for people who are dying of overdoses, and just watch that map. Watch the change in the years and all the overdoses that happen. And that ends in 2014, which is before fentanyl and carfentanil have actually even hit the United States. And once we start getting things that are 50 times, 100 times, 1,000 times the strength of street heroin, that's when we start to see the death spike. And so this map doesn't even show me that. Massachusetts was actually never a heavily prescribing opiate state. It just wasn't. And granted, we had some bad doctors out there. I know this for a fact, right? I trained in South Boston. We were handing out in the 1990s OxyContin to anybody who walked in with any problem. You're 17 years old, you got a migraine, here's some OxyContin. Because my medical school, not my medical school, my residency meals were brought to me by Purdue Pharma, right? They were feeding us, they had those cute little drug reps in the hospital, and I was starving and I was working 130 hours a week. And what was I? I was an intern, right? And they're saying to me, no one will get addicted, it's all good, use it at 120 milligrams 3 times a day. I didn't know what I was doing. Within about 6 months in South Boston, we were like, holy smokes, this drug is really strong and these kids are getting addicted. And we all pulled back. It didn't take us much to know that, but it was South Boston. It was really evident to us what was happening at the time. Most of the pills that came to New England came from Florida. And we used to call I-95 Oxy Highway for that reason. People would go to Florida where they had over 600 pill mills, and you would go there as a tourist and have a free trip on a bus that somebody organized, and you have all your meals paid for in your hotel rooms, and all you need to do was to walk into 2 pill mills a day. They were in the same strip mall. You didn't have to leave the strip mall, and you would walk in, no diagnosis, no cane, not even old, and you would walk out with a bag of pills and a pile of scripts, which you would hand back to your tour operator, and then they would go back to Kentucky and Western Mass and Gloucester, and they would sell it all. So when the DEA said to the state of Florida, if you cannot control your problem, we are cutting off all federal funding. No more highway funding, no more education funding. Your state is destroying the eastern seaboard. When that happened, and Florida shut down every one of its pill mills, nearly every one in the year 2009 and 2010, they sent 34 doctors to jail, to prison, because they weren't doctors, they were drug dealers. When that happened and the pill mill pipeline was shut down and you were left with the entire I-95 corridor covered with folks struggling with addiction, what was left? Yeah, right? We had this fabulous, potent, lovely heroin that had already been distributed. There's a book I'm going to show you at the end that talks about how this stuff gets distributed around the country. The cartels in Mexico knew exactly what we were doing. They knew about the pill mills. They knew they were getting shut down. They knew that we would need a great supply of opiates out there to meet the people who struggled with addiction. So this stuff is much deadlier than the pills, right? When people spend time, and I believe we need to curtail prescribing, people need to be much smarter, we can't be handing out tons of pills. I had knee surgery a month ago, and the guy who did my knee surgery didn't know who I was because he was new to the area, and I didn't tell him who I was. It was all good, right? He knew I was a doctor, blah, blah. He thought I was probably like some happy pumpkin, which I am. It's all good. So he handed me a script for 50 oxycodone. I had arthroscopic knee surgery, like nothing. I didn't even fill the script. So today I just saw him on the way here, and at the end I said, I just want to give you a little feedback. And he's like, okay, I'm sure nobody's ever done this to him, and I handed him back the script. I said, you don't know who I am, but I'm telling you, I'm an addiction specialist, and I'm a chronic pain and acute pain management specialist, and you cannot be handing, for arthroscopic surgery, 50 of anything to anyone. I don't know where you used to practice, but you're practicing in Massachusetts now. And you can't prescribe this way. He looked like he was about to fall over. So that ended up being a long visit where I did a lot of teaching about what it was that he was going to do in the future to help people without sending 50 oxycodone. Okay, so when you ask EMS what their #1 drug of concern, this is a map from 2015. The answer in the green areas was heroin. And what's amazing then is how is it the Southeast doesn't have a heroin problem? I-95 goes through there, right? What'd you say? Oh, you said meth, right? That's what a lot of people say, but actually the meth rates in the Southeast have actually been on the down, and actually meth in general have been on the down. So this is the most recent map, 2017 map. Those red areas now are heroin. So heroin is definitely in the last 2 years has perked up everywhere, my friends. But then why not sort of those other southern states? Like, how does Alabama and Louisiana and Arkansas, how are they getting away without much? This is the answer to that question. This is a complicated map. I just added this to my slide deck, and it's complicated. You're going to study it later. But those tall, spiky oranges are heroin. Those small purples are prescription drugs. So what is hard to see on this map, but I'm going to show you on this map here, is county by county data on the number of opiates prescribed in the county. And those dark counties on that map have on average 1 to 1.5 bottles of opiate per person in that county. So look where the prescription opiates are still happening. This is what is this map from? 2016. So, but look at it. Look at that very far eastern part of New Hampshire. Look at that one county. I don't know what county that is in Maine. That's not Aroostook County. It's something just to the west. That probably represents 3 doctors. That's my guess. That's the middle of nowhere, Maine. But look at the number of prescriptions there, right? But look at most of New England. There's not a lot of prescribed opiates, right? Our problem is heroin and fentanyl and carfentanil, right? It's not the prescribed opiates that are killing our people. Again, you guys are going to go home and study these slide decks. I know I'm throwing a lot of data at you. So how do our kids get this stuff? In general, our kids do not get opiates if it's not in their house, right? Unless they're prescribed opiates. And so our kids will get opiates if they get injured. If they have an ACL tear, or they break their femur because they're a football player, or they get their wisdom teeth out, right? And this is what I'll say. So who had kids or had oral surgery themselves in the last couple of years? Anybody? What did you get, Lisa, for opiates? Did you get anything?
Well, my daughter just had knee surgery. It was a pretty severe knee surgery, but they gave her 5 milligrams of oxycodone.
How many, do you remember?
Enough for 3 days.
For 3 days. So
yeah, it was Boston Children's.
Yeah, so 3 days.
And she
5 milligrams.
chose not to take them.
And she chose not to take them.
Yeah, I filled it and then I turned it.
And then you turned it in.
Because she
that is pretty judicious prescribing. 3 days after a big knee surgery. What did you get?
I got Tylenol.
You got straight Tylenol. You had oral surgery?
For 6 weeks.
Straight Tylenol for 6 twisted teeth. Yeah. Not Tylenol with codeine. You got Tylenol? Jesus. Five zero? Okay. So, wow. Okay, so, give me another one.
I just had my hip replacement 3 weeks ago, and with 35 milligrams.
You have that for a hip surgery. That's actually not very generous. And how much did you use? Yeah, but did you?
I didn't even use this.
You didn't even use them all. Yeah, that's right. So you are hearing a major trend, which is positive. We used to really overprescribe and give way, way too much, but the numbers are coming down. Yep.
I got my wisdom teeth out when I was like 16. I got 30%.
30. How many did you use, may I ask you?
I think I used like maybe 5 or 6. My mom didn't really let me use them unless I was in a lot of pain.
Right, because your mother was paying attention. Do you know how many young people took their 30 or their 60 and just ate them all, right? That's the launching pad for a lot of people with addiction. Yeah.
I think one of the areas, too, that we're not looking at that shocked me, and I only realized this because my elder parents live with me, and my dad was on hospice, but when he came home, he was only home for 2 days, but hospice sends out a case in the mail loaded with more liquid fentanyl patches, like a whole case.
Yep.
And by the time the case got to our home, my father had already passed.
Yep.
So this case I hadn't even opened.
Yep.
So I went to the hospice and I said, look, this hasn't even been opened. Please take it back. Use it for someone that doesn't have insurance. I don't know.
Yep.
They said, oh no, we can't
Can't
take
do it.
that.
Can't take it back.
And I thought, my God,
Yep.
what am I going to do?
And for people who are going to be on hospice for a long time, you actually do want that emergency case at home. But hospices that are doing their jobs now have got to go back and extract those drugs and get it to police take back. The problem is most of the take backs won't take liquid, and a lot of that morphine is liquid. But so you guys are telling me some really positive news, which I'm getting more and more often, that prescribing is getting down, that people are paying attention more, and that people are getting rid of their stuff and drug take backs, right? The conversation about pills, we're going to continue to have it, but today's problem is heroin, right? And I'm not going to get lost and stuck on the fact that heroin is our real problem. What were you going to add?
Well, first of all, what I was sent home with pain med was based on what I took in the hospital.
Yeah.
But I just don't understand, and I'm sure you're going to get to it, why this isn't part of education in the middle schools. Where's the DARE programs? Why?
Right.
Nip it in the bud.
Well, so one of the things I will say is are we talking enough about substance use disorder to teenagers, right? Like a talk like this, any teacher in this room can go give this talk. Any health teacher could be giving this talk. I believe that educating kids with the facts makes them make better decisions. The DARE programs have been studied up one side, down another, and scare tactics in general actually don't work very well. But actually teaching knowledge about, hey, do you know what your brain is doing between the ages of 12 and 24? And do you know how easy it is to disrupt that? Like, the reason that I say take my slides and give the talk is I don't care who does this. I need people to go out and talk about this stuff to teenagers, right? That's who needs to hear this stuff. If you're a parent and you're paying attention to your kids' rooms, you need to be paying attention to your kids' rooms, because you've got, this is a learn to cope slide that I stole from them. And I don't clean my kids' rooms, I don't do their laundry, I go in there and I get high blood pressure and I start yelling because they're just a bunch of pigsty kids. But I go through the rooms and I look for worrisome signs. They don't even know what I'm looking for, they don't even know that I go through their rooms. It's my house, I'm feeding and clothing them, I get to go through their stuff as far as I'm concerned. But whenever I have a parent bring in their 23-year-old and they find out their kid's been shooting dope for the last 4 years under their roof, they're stunned, right? And I think to myself, I'm not judging, honestly. I want to be the parent who figured out my kid was struggling 3 months in. That's my goal. I don't want to be the parent who didn't figure it out for 3 years. So you got to pay attention, because if you're looking, you will find stuff, because kids get sloppy. Over time, they just stop hiding things as much, partly because they're probably looking for help. But parents will say they were begging me for bags of cotton balls, they needed lots of boxes of Q-tips, they were asking me for bottles of bleach and vinegar to clean the works. Your kids are not cleaning with bleach and vinegar, right? And if parents had known what these signs meant earlier, they would have stepped in early. They just didn't know. So you guys haven't learned to cope somewhere locally? You do. And Learn to Cope is an amazing support group for parents and family members. And they just, if your kid is struggling and you're not part of Learn to Cope, I'm going to encourage you to be so. They do great work. And they also train you on how to use Narcan. So you guys know this already, because I got quick and smart people in this room. Who carries Narcan on them? Lots of you. I mean, a lot of you in this room are emergency medical responders. Somebody goes down, you think they're not looking at you? I have Narcan in my purse, I have it in my car, because I know if somebody goes down, I end up being one of the people who has to respond. So Narcan is available at any pharmacy in Massachusetts very soon, but right now it's very easily available at every Walgreens and every CVS in the state. You do not need a prescription, you walk in, it's run under your insurance. What if you give Narcan to somebody who's having a seizure? No negative impact. Is it going to help them? No. You call 911 first 100% of the time. Are you in any way liable by using Narcan? No. We're in a good Samaritan state. You can use it. I'm liable because I have a doctor's license, actually. If I screw up somehow, they're going to come after me. But I won't talk about that.
So anyone can walk in a pharmacy and get Narcan?
Yes, to the pharmacy without a prescription. CVS, Walgreens, but the state...
They charge your insurance?
They charge your insurance, yeah. And they're not supposed to ask you who it's for. It's none of their business. Yep, that's the rule. Massachusetts. But many more states are doing it. So I want to just say just a couple things. Because guess what? People get better. People get better. They don't get better fast enough sometimes. They don't get better the first time. They get better the 107th time sometimes. But what does it take to get better? It takes lots of things to get better. It's not one thing. And on everybody's pie, I sit down with people all the time and I make a little circle. And I say, this is what it takes to get better. And you need to tell me what it takes. On everybody's pie of what it takes to get better, there's a piece of the pie that has to do with structured, sober living. And if you are going to go home and live with somebody who's shooting dope or drinking really hard, you will not make it. And if your community is fighting sober living, you need to stand up and say, we need places for our people to go. Because 5-day detoxes put people in harm's way. That's what they do. You know what it takes to get better? Months and months and years. You need sober living where people can stay for a year and a half, or 2 years. Contribute to society. And there's nobody who gets better without sober living, period. And that is a major, major, major shortage in the state of Massachusetts. What else does it take? I'm a believer in medical assisted treatment, whether it's for alcohol, whether it's for opiate use disorder, methadone, buprenorphine, Vivitrol, also known as naltrexone. That helps some people. Having a sense of purpose makes people better. Going to school, raising your kids, having a job. All of these things, good mental health care, lots of physical exercise, treatment for your trauma, there are many, many pieces to everybody's pie. When I'm sitting with a patient, I'm saying to them, what do you think it's going to take? Yesterday I had somebody who said, I need to be able to do my art. My art is the one thing that makes me better. I said, awesome, let's put it on there. You need your art, we've got to make that work for you as you try to get better. So some people's pies are really complicated, some people's pies are pretty simple, but it's not one thing. It's not 12-step programs, 90 meetings in 90 days, and that's the only way through this. As addiction people, we have got to be less judgmental about what it takes for people to get better. It takes lots of things to get better, and sometimes it takes just one thing for you to relapse again. These books up here are books that I've liked in the last 8 years that I think were really good reads. Most of you in this room have read some of these books. The book called The Body Keeps the Score is the best book on trauma I've ever read. It's an amazing, who's read that book? Anybody? What do you do for work?
Counselor.
You're a counselor, okay. A great book, right? Awesome. Changed how I am as a doctor. No book has impacted me more in the last 10 years than that book right there. If you are anything in the substance use world, anything, I think police should read this book. If you are interacting with people who struggle, The Body Keeps the Score is going to help you understand what happens to the brain and the body with a history of trauma. But all those other books, The Realm of Hungry Ghosts by Gabor Mate, the book Dreamland is about the distribution of heroin throughout the country. It's pretty non-violent. It's incredibly high-tech. It involves Uber and Lyft and texting and airplanes. And it is not going to get shut down by building a giant wall. I am going to say that when dopamine gets better, and it does get better, but it takes time, 1.5 years, 24 months, 2.5 years, what makes dopamine better? Lots of things. Falling in love, taking care of an animal, being able to care for your kids or your elderly mom, having a job, going to school, having a sense of purpose, lots of physical movement. That builds dopamine in the brain. You know what doesn't make your brain better? Going to jail. Getting locked up in a cell. That doesn't make you better. And the fact that we lock everybody up with their disease and addiction, and I'll be honest, your county is the worst jail in the state, right there. I just said it. I don't care who works in the sheriff's department here, but I need somebody to run for sheriff of Bristol County. That's what I need. Because you guys have a bad reputation. You really do. I mean, I'm the doctor of the jail. And I hate to say it, that we mock this county, a county that needs more help, actually, than many other counties, and you have no treatment that I can tell is happening at Bristol County House of Corrections. And I'm very upset about that. If every day I think if I could be cloned, really, and my top 3 things I would do is I would run for sheriff here. I would kick some ass.
But they say they do. How do you really?
I'm telling you, by anybody's standard, right? When you think about what works for treatment at a jail, right? It's not hitting rocks. It is not getting shackled and working the roads. That's not treatment. Treatment is true, trauma-informed cognitive behavioral therapy. My jail does yoga for trauma. We do music therapy for trauma. We do CBT, ACT, every known evidence-based treatment for treating addiction and trauma. We don't just have AA meetings that come to the pod once a week. That's not real treatment. You know who these people are? They're your kids, they're your nephews, they're next door neighbors, and they're coming out one day. And you want them to have gotten better and not gotten worse while they were in jail. That's what I say. And you know what's coming down the pipelines, my friend? If you struggle with addiction, you should be getting medicine for your addiction in jail. That is the standard of care in our fine southern state of Rhode Island, where every person who's incarcerated in the state of Rhode Island with an opiate use disorder is screened for their addiction, and they are offered buprenorphine, methadone, or Vivitrol. Done. Right? Congratulations to that great state of Rhode Island, because they're kicking some serious butt right now. And I hate when Massachusetts runs behind, but we're running miles behind Rhode Island right now. You know what? I have one more slide, and then I'm going all to questions. And what's my last slide? Oh, I have a website, and the website is myname.com. And the only reason I'm mentioning it is because I have videos there. It's my talks. It's a variety of talks. But for some people who do treatment with people, sometimes showing a clip of a video is a really good launching discussion place, right? People use these things in treatment. If you have somebody who you wish had heard some of this, just go to the website. I have a calendar that shows where I'm speaking other places. And there's something else there. I can't remember what else is there. Hold on. So I'm going to go back to the book page. Okay, now I have no more slides, and everybody who wants a slide is going to sign up and back, and Lisa's going to take care of you, and now we're going to be all questions. Yes?
Will you guys come to the...
Yeah, we come to the mic. It actually is hard.
There's 2 microphones. So
there's 2 mics on either side.
Well, I can speak loud. What do you think is the most complicated condition you've ever had to treat?
Of all diseases I've ever taken care of? You know, addiction's right up there. I'm going to say that. And again, I take care of really, really sick people. I take care of people with end organ failure. And then, you know, today I had a guy who's on dialysis and has congestive heart failure and had his foot amputated. The truth is, I actually know he's going to get better. He's not going to live forever, but he just started dialysis, and today I thought, you're going to get better. And the next patient I saw in the room was a 24-year-old kid who I just can't get traction with, right? Still shooting up every day, using coke. And between those 2 people, the 70-year-old who's on dialysis with congestive heart failure and an amputated foot, he's going to live longer than that 24-year-old patient that followed him. Addiction is one of the most complicated diseases I've ever taken care of because it breaks the brain in this very specific way, and it's really hard to get enough structure and support for you to get better. And we're all living in a world helping people with addiction without enough resources. If I had sober living for all my people to go to, man, I'd be in good shape, but I got nothing going on, nothing. So you want to, I don't know, if you want to invest in the goodness of the human, life in our community, you've got to start building some sober living. And we have people that run sober living in this room that do really good work, but we probably need that times 10, times 20. So it's one of the most difficult. I take care of a lot of mentally ill people. Mental illness is really hard. So that maybe is right up on my list too. Really severe, unremitting suicidality kills me every day. Yeah.
I just want to, I'm so glad you said the mental health, because what I do for a living is I'm a co-occurring disorders person. So I work with people that have the most severest mental illness together with addiction. Yeah. And I'm so glad that I came here because I was like so tired. I'm like, I'm not going to come, but I think that the trauma is the real thing, and I'm so glad that you mentioned that because trauma-informed care, I've been learning about it for years, but I haven't heard any. They have the National Institute, the NIDA, that I went to that was all about the changes in the DSM. Yep. But what about our poor folks that are, I have a guy that takes 400 milligrams of cholesteral, and he drinks. I'm trying to get it, I just feel like as a provider, as somebody, and I care so deeply, and I know that recovery is possible, what can I do to help that? Which is a large discussion, but this is I thought addiction was a bad thing, and I got out of addiction because I got empathy exhaustion from people dying and things. So I went to the mental health, and now I'm here, and I got the best of both worlds crashing in on me.
I bet you do. They're both the best and the hardest of both worlds. So you take somebody with addiction, and then you have them have major mental illness and poverty and no resources, and they're really hard to help enough because they need so many resources. So when the state of Massachusetts, along with most of the country, shut down all of its residential mental health places, that was probably pretty good, but they didn't replace it with anything. So you know what our residential mental health treatment centers are in the state? Jails, right? That's what it is, just jail.
We have CBFS.
What was that?
We have CBFS.
Is that a good place where you can live for years with your major mental illness? Oh, that's good to know.
Yep, they have, it's a funded by the DMH. So people that are getting out of the state hospital can go and live in what we call a GLE, but it's minute if you look at the big picture.
Right. We need a lot more respite and residential housing and DMH caseworkers. Your person needs a caseworker who's following them. That person's really sick to be on Clozaril and to be drinking heavily. That person needs a lot of support and love coming their way and a tremendous amount of structured support. We have to fund it because you know what? These people cost a lot of money too. They just do. They are in and out of the hospital, they're in and out of the ER, and you think it's expensive to actually treat people, try not treating them. That's really expensive. Yeah.
Do they, I don't know if there's been any studies looking at younger children who are on prescription drugs. There's so many children now that are on ADD, ADHD, anxiety, you name it, they're on it and at a young age. And I just wonder if they've found any correlation with those children growing to be addicted, later taking a pill, a medicine.
Yeah. So this is always a question that gets asked, is what is the correlation between early treatment with pharmaceuticals in adolescents or even way younger than that in addiction? So first of all, I think that ADHD is overdiagnosed in our society. When you look at the statistics on ADHD, it's about 4%, maybe 5% of society. There are western suburbs of Boston where there's a lot of money, where they expect their kids to go to Harvard, where their rates of ADD stimulant drugs are like 20 to 30%. Those kids don't have ADHD. Those are performance-enhancing drugs being promoted by their parents. That's what I think.
My daughter was on swim team, USA swim team in Metro West, very affluent. Most of those kids, those parents, and she was 6, 7, 8. That was the team.
That was her cohort. She's swimming in the Metro West, and most of her team are on stimulants.
Yeah.
Really? Do you think that's real? It isn't real. So if you take a kid who doesn't really have ADHD and give them a stimulant, I think that's probably not good for their brain. Having said that, I don't want you to mishear me. That 5% of kids who really have a diagnosis of ADHD are really suffering. They are not thriving in school, they are not learning, they are making no friends, they are pissing off their teachers and every one of their peers. They are miserable. And when I get those kids in my office and their parents are like, I'd like to try an herbal product for their ADHD, I'm like, look at your 7-year-old. They have no friends, they are miserable, and I am telling you, by every score possible, this kid has ADHD. Will you please let us try some medicine? And when that kid comes back and they're happy and they're not interrupting classroom and they're not sitting in the corner all day long and they're actually able to follow direction and get their work done, they feel so much better. And the studies show the overlay between ADHD and addiction is quite high. About 30% of people with addiction have ADHD. So it's a chicken and egg question. Did the ADHD meds create the disease of addiction? Most of us don't think so. If you truly have ADHD and you get treated, you actually do better with your substance use disorder because you're controlling that bad impulse control, right? So much of ADD is just yes, 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 you know, impulse without really thinking, that sort of not a great prefrontal cortex. And so what I find is that if I have somebody who truly has a childhood diagnosis of ADHD under the age of 12, meets the criteria, and I have them in my room as an adult, I'm going to treat their ADHD because it helps them get better from addiction. So I'm answering your question in a complicated way. When it comes to the ADHD meds, I think we overdiagnose and overtreat. And then I think we may create a problem. But for the kids who really have ADHD, there's no evidence that we create addiction. And in fact, I would argue that the self-medication that kids who have ADHD might do, right, because they're not getting treated, actually puts them in harm's way. First of all, we're not giving our kids benzos. We're not giving them Valium and Xanax, but we used to. Back in the battle days, I guess you would give a 14-year-old benzos, right? That doesn't happen anymore because those are...
It does.
Today's kids are getting benzos?
Yes.
Well, that's appalling, and I would stop seeing that physician because those are dependency-inducing drugs, and I wouldn't use them. If my 15-year-old was depressed and I was doing all the treatments for depression, lots of exercise, lots of therapy, cognitive behavioral work, meditation, they weren't getting better, I absolutely would use an SSRI, right? I would give them Celexa or Lexapro, Prozac. I want my kid not to self-medicate with marijuana or alcohol because I'm not managing their anxiety and depression. I prescribe a lot of SSRIs and SNRIs because it helps
There's a
people.
lot of high school kids. We work in the high school population.
Yeah.
Nurse. You would not believe kids have come in are on TID benzoids.
I am stunned by that. I can't
So
believe.
wasn't I.
Yeah, I can't believe that's happening, and that makes me a little alarmed about who's prescribing to adolescents. That's a problem as far as I'm concerned. First-line treatment for anxiety and depression are the non-dependency-inducing SSRIs and SNRIs, period, right? And it's hard to find good psych prescribers. There's not many of them out there. Let me take some other questions on this side. I just want to make sure I'm not ignoring people. Yeah.
Speak briefly about the brain recovery, especially the brain receptors.
So she's asking a question about the brain getting better, and so I talked about that. It does get better. It does get better. And it gets better even if you're using methadone or Suboxone or Vivitrol. It gets better when people get their life back on track. So all of those things I listed, what builds dopamine in the brain? Again, falling in love, taking care of other human beings, feeling like you're not a piece of dirt all the time. You know who has the lowest self-esteem, who hates themselves more than anybody else? The addict. They hate themselves, right? They really do. There's no self-loving addict out there. They feel like dirt every day. They are made to feel like dirt every day. And, you know, when you get better, you actually start to build self-esteem. And what does it take to get there? We got to be able to hire people, even if they have a Corey, even if they spent time in jail. People need to have a sense of purpose and something to do, and not letting them have public housing because they have an old Corey. It's really bad, honestly. Drug courts can be very effective, but if drug court is so restrictive that you can never have a job, then drug court's not doing its job, right? I spoke to drug court last week and I read on the Riot Act because I'm like, you guys have got to be more flexible, right? Do your drug court at night, but people need to go after school and they need to have a job. How do I know somebody's better? I say, show me your bank account. Show me your bank account statement, right? You got your car back on the road, you paid off your debts, you paid off the court fines, and you're doing this thing, and you're saving money. I don't need to do a urine blood screen on you. You're doing better. That's all I needed to know, right? When you're using, you got nothing left. You sold your car. You got nothing in your bank account. So let me maybe take one other question or two other questions.
Correct me if I'm wrong, because it's my understanding from people I've seen it happen to. A, private insurances don't pay for overnight rehabs. A lot of rehabs are being paid out of pocket by families. And B, if a child is ready to start, like I want to, you know, kick the habit. There's only so many doctors that can prescribe these Suboxones, and the doctors are full. It's hard to get in to get a prescription for these medications.
So
there's no doctors.
The parity law in Massachusetts, in the rules that probably Cheryl is the one who promulgated these things, all insurance in Massachusetts, private or public, is mandated to cover treatment, right? And so we talk about beds and we talk about detoxes, but they're mandated to cover at least 14 days, and some of them cover even more than that. That's the rule. You can't be in Massachusetts with insurance and not do that. Mass Health covers it. Every Mass Health product is required to cover. Now, if you want to go to some fancy-dancy place somewhere out there and you want to have massages with your recovery, that's not going to get covered, right? That does exist a little bit in Massachusetts, but there are some private pay places that cost $1 gazillion. I run a treatment center that's where we just take care of Mass Health patients, from what I can tell. And everybody's there for at least 14 days if they're willing to stay that long, but some of them are there for 30 days or longer. So first of all, when buprenorphine came out, which is what Suboxone is, it came out in the year 2002. And the plan was that you would just do your job as a primary care doctor and take care of people with addiction. That was the plan. And I remember being a resident and going down and getting my waiver, right down here, in fact, in 2002. And we went down with the entire family medicine department. 30 of us went down and got our waivers, all at the same time, because we're like, that's our job. Well, we probably must have been the only people who did it, is what I will say, because lo and behold, there were no people getting their waivers. By 2014, only 2% of American doctors had done this stupid training that takes 8 hours to get their waiver to prescribe buprenorphine. In the meantime, they were prescribing 18 billion opiates every day under no supervision, with no waiver, with nothing, right? So I don't know how this all happened. You shouldn't need to waiver in the beginning at all. You should learn to know what you do the way that any of us learned to prescribe hypertension meds. I didn't just make it up one day. I taught myself or learned how to do it, and then I started to prescribe. So at this point, there's not enough buprenorphine providers throughout the country. There probably are not enough buprenorphine providers in this region. I think that's fair to say. You guys have people who've been very brave in this region, who have been prescribing way outside the federal limits because they're courageous, quite honestly. But the community health center locally is going to start a buprenorphine program. The local hospital, St. Anne's, is going to start doing some inductions to buprenorphine with a warm handoff to a community site. And you guys have some freestanding just addiction treatment like Clean Slate, right? So Clean Slate stepped into the void. You know what? Doctors didn't do their job, so people looked around and said, we're going to do the job for them. I don't work for Clean Slate, but I'm grateful for the for-profit places that stepped in, because you think we have a problem now. What if for-profit places like that didn't exist? I'm all in favor of places like that as long as they take insurance. I do not support cash-based businesses. You walk into my office and I'm supposed to write you a script and you give me $100. I'm a drug dealer at that point, right? You should always take insurance. We are in a state where 98% of us have insurance. Take their insurance and stop having this be a cash business. That's unethical as far as I'm concerned. So maybe, let me take another one in the back over here. Yep.
You pointed out like a lot of issues we have in public policy surrounding addiction. Do you have any sort of recommendations that like we as everyday people can kind of do to help change public policy? Because obviously we can all do our jobs basically, but it's not going to take care of the problem as a whole.
Yep.
Unless we get some sort of support from public policy.
I totally agree with that. I have to say, I think in Massachusetts, I think that under Deval Patrick and then under Charlie Baker, I think that we at the leadership level in Boston have done a pretty good job. But what worries me now is the focus has always been on the prescription pills. And like now that everybody's patted themselves on the back for curtailing doctor prescribing, they think they're all done. And I don't know what you've heard coming from Boston recently in the last year or two about changes. I haven't heard a lot, and it causes me a lot of concern. So I think you have to keep pushing people. Like here I am saying, we need long-term sober living, so let's keep funding long-term sober living. People talk about beds still. We actually have enough treatment beds in the state. Our numbers are pretty good. They should all be sitting pretty much full, but most places have places. I would say that you should be asking, when you walk into your primary care doctor's office, you should ask the question, what are you doing to help people with addiction? And if their answer is, not my problem, I don't want those people in their waiting room, man, that doesn't feel so good, right? Most doctors should do their damn jobs. They just do your damn job. I got a cardiologist. It's actually not the cardiologist's job to treat addiction, but he stepped into the void because he cares about this community, right? It's really the job of those of us who are frontline, battling primary care people. That's our job, and most of us are not doing our job. I think your local hospitals, I think St. Anne's is starting to head the right direction. I think most hospitals are not doing what they're supposed to do. When you have somebody who just had a Narcan use in the field and gets brought into the ER and they're sick as dogs, and the recovery coach is there, you know what the right thing is to do? Start them on Suboxone right there and then. Start them up, done. You give them a 7-day supply. 80% of those people are continued in treatment by day 30. That study's been done already. It was done at Yale. They've been doing it for the last 6 years. The ER is not doing their jobs, and I can say that across the entire state. There are very few ERs that are doing straight inductions. Your local hospital should be doing inductions to treatment. They're holding on to these people for 20, 30, 60 days because they're really sick. Get them stable on treatment and get them into a community provider. That should be their job. So I think there's some local grassroots stuff that can be done. I think we should still be pressing our legislators in Boston to still do more, because this problem, I don't think it's gotten better yet, my friends. I just don't think it's getting better, and I'm not being a doomsday person. So how about this, because I know people have got to go. I'm going to be here for a little bit longer. If people have other questions, maybe you could talk to me afterwards. Is that okay? Thank you for coming out tonight.